in this part, let's move on to the lower respiratory tract and the exchange of gases. So, if the upper respiratory tract is involved with filtering and moistening the air and humidifying, of course, the air, so we have the lower respiratory tract that has the main function is to move the inhaled air to the respiratory membrane. And of course, this is where the exchange of gases occur. So the structures here include the trachea, the bronchial tree, and the lungs. So we have here two zones, the conducting zone and the respiratory zone. The conducting zone is the physiologically the upper tract and the first portion of the lower tract. So as its name suggests, it conducts the air from the atmosphere to the respiratory zone deep within the body, which is of course the lungs. So this includes the structures of the upper respiratory tract as well as the trachea, bronchi, bronchioles, and the terminal bronchioles. So the respiratory zone lies deep within the lungs. This is where the actual exchange of gases takes place. This includes only the respiratory bronchioles, the alveolar ducts, alveolar sac, and the alveoli. So here is an image of your lower respiratory tract. So as you can see, again, the larynx is the dividing area or dividing region. We have the trachea, and of course, these are the bronchi. So we have the primary bronchi. The trachea divides into the primary bronchi, the secondary, and so on. Now, this is called the bronchial tree because, well, of course, it resembles branches of a tree because the passageway branches out. So, let's see the trachea. So, the trachea connects the larynx and the bronchi. It's composed of muscular walls embedded with 16 to 20 C-shaped pieces of hyaline cartilage. So, these are not bone but cartilage. So, these C-rings provide the support to the trachea so it won't collapse during breathing. Because in here, it is very important, especially in the act of respiration, it's very important the pressure is very important. So at lower pressures, when you breathe out, you won't. It prevents the trachea from collapsing. So at the lower base is what we call the carina. It is the last ring of the tracheal cartilage. The mucous membrane of the carina is more sensitive to touch than any other area of the larynx and the trachea. So this spot is the one that triggers the dramatic cough reflex when any solid object touches it. So, the lower portion of the conducting zone and the respiratory zone are collectively referred as the bronchial tree because, again, it's branching. So, the trachea splits into two tubes, which is the primary bronchi, and we have this is at the level of the fifth thoracic vertebra. So, that means this is actually, if you count if you can actually feel the individual vertebra at the back. So, if you count the fifth thoracic vertebra, so that's where it approximately branches out. So the primary bronchi divide into the secondary bronchi inside the lung. So the right bronchus divides into the three secondary bronchi. So one for each lobe of the right lung. So the right lung is larger than the left lung because the left lung only divides into two secondary and has two lobes. Why is the left lung smaller than the right lung? Because you have the heart on the left side. Now, the secondary bronchi branch off into 10 tertiary bronchi in each lung. So, again, like a tree, it forms many branches. Why does it have to form many branches? It maximizes the surface area. That is to maximize the surface area because the exchange of gases happens on the surface. Okay? So, that means you must have a maximum surface area. So, the terminal bronchioles get smaller and branch into respiratory bronchioles. And the respiratory bronchioles branch into alveolar ducts, which lead to the alveolar sac, which has the alveoli. So, the bronchial tree undergoes two major changes that reaches deeper into the body. So, we have cells of the mucous membrane gets smaller. We have pseudostratified type of columnar epithelium in this side. So, we have significant mucous secretion in which cilia sweep upward. So, the terminal bronchioles have no cilia and are lined with simple columnar epithelium. So, if dust reaches this area, it's up to the macrophages. Macrophage, by the way, are part of the immune system. So these are large cells that actually eats. That's why it's called phage. So macro, large, and phage means it. So they are big eaters. So they eat any debris, bacteria, and virus that are in the lungs. So they are the janitors patrolling the lungs. So the composition of the walls of the bronchi and the bronchioles changes. So we have the amount of cartilage decreases as the size of the bronchi and bronchioles decrease. Simultaneously, the amount of the smooth muscle increases. Without the cartilage, the smaller tubes can be completely shut by contraction of the smooth muscles. So, we have asthma and obstructive respiratory diseases targeting this smooth muscle, and they become irritated, and it causes them to tighten. So, that's why asthma has difficulty in breathing, because, again, the bronchial, the smaller bronchial tubes are closed. So for the lungs is the lightweight organs that extend from just above the clavicle to the 12 thoracic vertebrae, and they fill up the rib cage. So the base of the lungs is a broad portion sitting on the diaphragm. The diaphragm is the one that induces the differences in pressure that allows us to inhale and exhale. Anyway, the apex of the lungs is a small point extending above the clavicles. So the lungs are paired, but they are not identical, as you can see in the previous slide. So we have a larger right lung, has 3 lobes. It is shorter and fatter, whereas the left lung is thinner and has 2 lobes. It's smaller because you have a space for the heart. So the space for the heart is called the cardiac notch on the medial side. That means around the middle. So the lungs are covered in a serous membrane called the pleura. So the pleura is some sort of a lubricant. So when we inhale, of course, the lungs expand. So the pleura allows the movement when you breathe in and out to slide smoothly. The lungs to slide smoothly inside the thoracic cavity. So you have the visceral pleura, snug against the lung tissue, the parietal pleura, which lines the walls of the thoracic cavity, and the pleural cavity between the 2 pleural membranes containing the serous fluid. So the serous fluid is the one that actually provides the lubrication. So this is your lungs. So you have an apex and, of course, the different lobes. So this is the cardiac notch. This is where the heart is. Okay? So this is basically your lungs. So this is coated by your pleura, the different pleura. So you have the visceral and parietal pleura. Now, this is the visceral and this is the parietal pleura. So it covers. Okay, so the pleural space is technically a vacuum. So if the partial vacuum inside the pleural space is lost, inhalation becomes difficult. That is why if you have stabbing or gunshots, because the lungs is technically like a balloon, so it's able to maintain this shape, this larger expanded shape because of the vacuum inside. Now if it happens that there is a puncture in your pleural space and it allows air to enter, so you will have what you call a collapsed lung. So this is an example of a collapsed lung. So you can see, again, the lung is like a balloon. So if you have a collapsed lung, so it's like a balloon that, well, basically has no air. So it deflates. So pneumothorax is when an injury causes air to rush into the pleural space. And when we have a hemothorax, when an injury causes blood to accumulate in the pleural space. So either of the two is actually very detrimental. So if the blood air, or if even bladder air fills in the space, it can cause the lungs to collapse. So pleurisy is the inflammation of your pleural membrane. So of course, a collapsed lung is you will have pain and difficulty in breathing. So let's look at the bronchopulmonary segment. So this is the terminal bronchiole. So the lungs has each lung has a different number of secondary bronchi. So the lung has 10 terminal bronchioles, each supplying one bronchopulmonary segment. So they look like a bunch of grapes if you look at it from the outside. So they are covered in elastic connective tissue, and they contain the terminal bronchioles, the respiratory bronchioles, alveolar ducts, alveolar sac, and the alveoli. So this is your bronchopulmonary segment. So alveoli. So let's look at the alveoli. So this is the alveolar sac, and this individual grape, well, if it looks like a grape, it's individual grape-like sacs. Those are your alveoli. So alveoli is the functional unit of the lungs. This is where the gases diffuse. So oxygen enters the bloodstream and the carbon dioxide exits. So they have a cup-shaped membrane and are clustered into, basically they look like grapes. So they are composed of just a simple squamous epithelium. Why? Because it allows movement of the gases. So the gases move through diffusion. So the septal cells scattered through the alveoli produces a surfactant. So this is a detergent-like fluid that moistens the alveoli but prevents their walls from sticking together during exhalation. Because again, when we exhale, there is we will have a negative pressure inside the lungs, and of course it's like a balloon. So inhale, the balloon expands. Exhale, it shrinks. So to prevent the total collapse of the alveoli, we have your surfactants, the septal cells. So the alveolar macrophages patrol the alveoli, so it keeps it clean. Okay. So this is the anatomy of the alveolus and the respiratory membrane. So this is your alveolus. Well, alveolus singular for alveoli. So anyway, you have your elastic fiber. So respiratory membrane consists of the alveolar cells, the epithelial basement membrane, the capillary basal membrane, and your endothelium of the capillary. So oxygen diffuses from the alveoli to the blood in the capillary, while carbon dioxide diffuses from the capillary to the alveoli. So if you look at this one closely, so here is this is the blood vessels, and you have a diffusion of carbon dioxide out and diffusion of oxygen in. So this is basically passive diffusion. So why does oxygen comes in and why does carbon dioxide comes out? Why it's not the other way around? Because the blood that goes to the lungs is low in oxygen. So of course, when we have a passive movement, so it goes from area of large concentration to low concentration. So you have your high concentration of oxygen inside this alveolar sac, and you have a lower oxygen concentration in the blood vessels. So you have, of course, oxygen enters goes from the high to the low. So it enters the bloodstream, and the other the opposite is happening for carbon dioxide. So the blood that goes to the alveolar sacs is low in carbon dioxide. Low in oxygen but high in carbon dioxide. So the high carbon dioxide goes out, and because the atmospheric air, of course, is less than 1% carbon dioxide. So it's actually lower carbon dioxide in the air that we breathe inside the lungs. So anyway, that is for the exchange of gases. And then we have surfactants inside the cells. Inside the alveolar. So air is moved in and out of the respiratory system. So the respiration involves the interplay between the respiratory and the cardiovascular system. So as you can see here, the bloodstream, this is your capillaries. So the bloodstream is closely associated with each alveolar sac, and of course, there is only a very, very small difference, or rather, a very thin wall between the two. So it allows for efficient movement of the air. So the respiratory system moves the gases in and out of the body, while the cardiovascular system is the one that transports the gases within the body. So the pulmonary capillaries exchange gases in the lungs, while the systemic capillaries exchange gases in the body. So we will talk about the different circulatory, because we have two types of circulation in the body. We will talk about that next week. So anyway, pulmonary capillaries, wherever am I? So pulmonary ventilation is governed by Boyle's law. So which states that the volume of the gas varies inversely with its pressure. So again, pressure is very important in breathing. So when we inhale, so the diaphragm, which is below the lungs, so the diaphragm contracts and the chest expands. And of course, because of the expansion of the thoracic cavity, you will have it's a negative pressure. I got mixed it up before. So it's a negative pressure when you have inhalation, because the air must rush in. So air rushes in. So the decrease in pressure within the lungs allows the air to rush in. So the diaphragm contracts and it flattens out, causing the bottom of the thoracic cavity to drop and expand inside. So basically, it's the expansion. And aside from the diaphragm, there's also your intercostal muscles, which are the muscles between the ribs. So they contract to raise the ribs and expands the size of the rib cage. So again, the cavity expands. So since the lungs, because of the pleural space, basically the vacuum of the pleural space, the lungs must be closely connected to the walls of the thoracic cavity. If it's not closely connected to the walls of the thoracic cavity, you will have a collapsed lung, as you can see in the previous slides. But anyway, so once the thoracic cavity expands, you will have the lungs will also expand. So it will induce induce a negative pressure inside and allows the air from the outside to rush in. So the air will enter. Now we have an exhalation. Now the opposite happens for exhalation. So you have your relaxation of the diaphragm intercostal muscles. So that way your cavity, the lung cavity, your thoracic cavity will shrink. So it will then have a positive pressure. It will push out the air. So the increase in pressure will push out the air, and of course you have the exhalation. So here is your lungs during inhalation and exhalation. So as you can see here, these are the intercostal intercostal muscles, and these are the different muscles that are participating in breathing. And then during inhalation, the air moves in, and exhalation, the air moves out. So these are some pressure changes. So as you can see here, this is at rest for a relaxed diaphragm. So when you inhale, this diaphragm here contracts. So you have it basically flattens out. So you will have an expansion of the lungs. So of course it will induce the air to enter. When you exhale, this one relaxes. So it will push out the air. So it has something to do with pressure. So the respiratory rate is governed by the medulla oblongata and the pons in the brainstem. So how basically it's semi-voluntary. So when we don't think about it, our body naturally, of course, breathes. So but when we think about it, we can actually control our breathing rate. So the respiratory center in the medulla oblongata causes rhythmic contraction of the diaphragm, simulating the contraction for 2 seconds and allowing 3 seconds of rest. So this cycle repeats continuously unless overridden by higher brain function. So the body can sense the level of carbon dioxide and oxygen in the blood through the different chemoreceptors in the carotid artery and aorta. So if you have high carbon dioxide levels, it will immediately trigger an increase in the depth and rate of respiration. Now, for the respiratory volume, this is how this describes, of course, the volume of air that we inhale and the type of breathing that we do. So for a normal breathing, the volume of air inhaled per minute reflects the respiratory rate and the volume of each normal breath. This is called the tidal volume, which is around 500 ml. So when we have a forced inhalation, basically it's a voluntary of course when you think about inhaling a large amount of air. So you have what you call inspiratory reserve volume. So that's your inspiratory reserve volume. So this can inhale around 3.3 liters of additional air. That's for an adult male, and 1.9 liters for an adult female. So we can exhale about 1,000 ml for males and 700 ml for females. This is the expiratory reserve volume. As you notice, you have a greater amount of air inhaled versus the amount of air exhaled. So we have a vital capacity. This is the total volume of the air in the lungs that can inhale and exhale in one huge breath. Vital capacity is the sum of the inspiratory reserve volume, tidal volume, and expiratory reserve volume, and it's between 3.1 and 4.8 liters. So males generally have a larger volume. Now, as you can see here, it's not exactly equal. So the amount of air you inhale is not exactly equal to the amount you exhale. So we have what you call the reserve volume, which is the amount of air that remains in the lungs after a forced expiration. So this is necessary to prevent, of course, anatomical dead spaces and a collapse of the lungs. Well, although the pressure in the pleural cavity, pleural space prevents that, but we have your residual volume of 1.1 to 1.2 liters. So it holds the alveoli open and fills the anatomical dead space when you exhale. So this is the graph of your respiratory volume. So as you can see, this is your tidal volume, the normal breathing rate. And then you have expiratory reserve volume and the inspiratory reserve volume. So the inspiratory reserve capacity is higher than your expiratory one. So this is your functional residual capacity, and this is the inspiratory residual capacity. So you have this is your vital capacity, the sum of the expiratory reserve, the tidal, and the inspiratory. So this is the amount of breath you inhale or exhale forcefully. Whereas there is a space here, so there's a volume difference. We have your residual volume. So this is the total ng capacity. So this residual volume allows you to basically keep your alveoli open. So the reliance of the respiration on the cardiovascular system is because, of course, although we have the respiratory system facilitates air entering and exiting the lungs, but the actual exchange of gases relies on the cardiovascular system. So you have your oxygen entering the alveoli and the carbon dioxide leaving the alveoli through because of the concentrations of these gases in the bloodstream. So in external respiration, we have the driving force is the difference in the partial pressures of alveolar air and capillary blood. In internal respiration, the driving force is the partial pressure difference of the capillary blood and the tissue fluid. So these are the exchanges during internal and external respiration that drives the partial pressures of the oxygen and the carbon dioxide. So what do you mean by internal and external respiration? So in the external respiration, this is the respiration that happens in the lungs, exchange of gases happening in the lungs. So of course, we have the bloodstream that is low in oxygen and high in carbon dioxide, whereas the alveolar space has high oxygen and low carbon dioxide. So passive diffusion dictates that oxygen must go to the bloodstream, whereas you have, again, this is what it is. So because of the passive diffusion, you have the higher oxygen entering the bloodstream and the lower carbon dioxide exiting the bloodstream. Now, the internal respiration occurs between the cardiovascular system and the tissues inside the body. So when the oxygen reach blood, because the blood is refueled with oxygen from the lungs, it will go to the body. The oxygen-rich blood will enter the tissues, and inside the tissues we have a low oxygen content and high carbon dioxide content. So again, passive diffusion happens. So since the bloodstream here now has a high oxygen concentration, you will have the oxygen leaving the bloodstream towards the different tissues of the body. So basically, that's the movement of the air, the oxygen through the body. Okay. So this is your internal respiration. So in the next part, we'll discuss about internal respiration.